All right. Well, today we're going to have a session that looks at disparities in healthcare. My name is Marvin Malek. I'm one of the preceptors of the Northern New England Health Policy Internship Program, and I'm going to be presenting some slides later in this session, highlighting disparities in care and some actual recent data. But before that, we're going to get some more of a focus on the history of racism in the United States health in general and in the United States healthcare system in particular. And we're honored to have Donald Moore here as a guest. He's practiced internal medicine in the New York metro area for much of his career and currently is an adjunct professor of biology at Pace University. And Dr. Moore serves on the advisory board of the School of Arts and Sciences and advisor to the Collegiate Science and
Marvin,
Technology Entry Program. And
Marvin,
he's
can I
remains
interrupt
active
you?
at Yale Medical School. So take it away, Dr. Moore.
Okay, yeah, I think I would hate to bore them with more of that. So I can, oh, I need to, that's it.
Beautiful.
Okay. Racism, a social determinant of health. Um, this presentation started out as racism in medicine. Then I took it further into joining racism with the social determinant of health. And then I narrowed it further for today's presentation is racism, a social determinant of health. Okay, so you've seen this before. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. This is a reminder. And this is the World Health Organization, and health is a fundamental right. So I assume we're all on the same pages. So you may not have seen this one. This is by Schroeder in his New England Journal of Medicine article, We Can Do Better. And what he talks about here is the proportional contribution to premature death of the determinants of health. So we talk about the social determinants, but I want to show you the wider picture, which is the total determinants of health, meaning what causes you to die before it's your time. As you can see, 40% is your behavior. So, you smoke cigarettes, you drive drunk, you do all of those things. 40% will contribute. So if you eat well, exercise every day, and don't do all the bad things, you will reduce that. And so that's on you. Then the other part is on your parents and your ancestry. That's the genetic predisposition, right? Can't do much there. But what we can do a lot about is that other 30%. That's the social determinants. And of that, you could see a lot of it is social circumstances. That's basically your socioeconomic status. Another portion is the environment that you live in, which is also to some extent socioeconomic status. And then 10% is your healthcare. So if we spend $1 zillion, actually 20% of our GDP on health, but we're only able with that 10%, 20% of all the money we have, we can only control 10% of our health outcomes. So, is the definition of the social determinants of health? It's the WHO again says it's the conditions in which people are born, where they grow, where they work, where they live, and how they age. And I've told you a lot about all of those things about me in particular. What are the examples of the social determinants of health? Well, your income, your education, your occupation, what's it like of where you work, what your race is. If you're black, you're white, your experience is very different. If you're an immigrant, your experience is a lot different than if you are an American that is privileged. your early childhood experiences, and so on. So you could see there's a long list. I want to remind everybody that there are ways to measure how we're doing. It's not just a guess. It's not how you feel. We have specific public health uh, outcome measures. My favorite one is infant mortality. Infant mortality tells you how well your state is doing. What's your government doing for you? Your infant mortality rate will be terrible if you have a terrible government. It will be great if you have a great government. As you could see in the United States, if you compare the United States to all the other developed countries, we're the worst. And in some instances, in this particular comparison, you could see a place like Cuba, which nobody would want to live today because it's been so depraved. They're doing better as far as infant mortality. So it said their state in Cuba is taking care of them better than our state in America. Of course, you can see I also threw in China and Russia to show you how they compare. Um, Maternal mortality, that's now how good your healthcare delivery system is. So it's not just the state anymore, it's how much good healthcare you're getting. So mothers die if they have risk and you don't take care of that risk, meaning your health infrastructure is no good. And of course, we do poorly there. But I thought we spend 20%, so we should have the best, but we don't. We do better than Cuba and China with respect to that, but you can see a lot of countries, to my surprise, even Russia does better taking care of their mothers delivering babies. And if you put all of this together, you get life expectancy. So we don't live long in America. We have premature death, which is what this whole conversation is about, because we should live longer. In Japan, they live to 84, 85 years old. We're living to less than 80 years old. So they've got about 5 years ahead of us. Japan is a more homogeneous society. You'll see from this discussion that it's because we don't treat everybody fairly in America, which is why. So don't take my word for it. Take the US government's word. The Institute of Medicine in 2013 put this report out. It compared 17 high-income countries to America. And the conclusion is we have shorter lives and poorer health. And the statement was, in the United States, we have the highest or near highest prevalence of infant mortality, which I just showed you. Heart and lung diseases, those are cause-specific reasons to die. Heart, right? We spend all that money on heart and lung. We get a lot of STIs, right? Sexually transmitted infections, AIDS, right? Adolescent pregnancies, injuries, homicides, disability, gun violence, all of those things. And then we're disabled. If you get disabled young, you're going to die sooner than you should. And of course, all that ends up with decreased life expectancy. Health disparities. So some definitions here. In the United States, we use the term disparities as either racial or ethnic differences. And in the United States, it's primarily thought of due to structural racism and other forms of unjust discrimination that creates gaps in health. So disparities is just what you end up with. This person has a higher infant mortality, this group has a higher infant mortality. This person died sooner than they should from a heart attack, et cetera, et cetera. So we're going to dig deeper into why these things exist. So there is disparities. In the UK, which is a country similar to the way America looks, because they have populations that are that are discriminated against. They also had slavery. African slaves that were transported to England. They have populations that are treated differently there, so they call it inequities. So what is an inequity? So an inequity comes before the disparity. In order to get that disparity, why the disparity is a result of the inequity. So the inequity is the unfair and unavoidable difference is in health between groups of people within countries and between countries. So, in a place like Palestine, that's between countries or between populations. One population has a high life expectancy low infant mortality, low maternal mortality, while in the same land, you have another people that have high infant mortality and so on and so on. So they're not treated equally. So that's the inequity that result in the disparity. And health inequities in the social determinants of health lead to significant disparities. That's the point there. So let's deal with the more common one that we recognize, which is socioeconomic status. It refers to the social and economic factors that influence the positions the individual holds in society. So if you are a doctor, you have high status. You're going to live longer and so on. If you were born to a certain class, like if your last name is Trump or your last name is Musk, you're in a certain class, you're going to live longer, you're going to get better healthcare and so on. If you're educated, you're educated like a lawyer or a computer scientist or so, you're going to do well. If your income is high, you're going to live in good places. And if you just have a lot of money, you're going to do fine. Individuals with higher socioeconomic status consistently experience better health outcomes than those with lower socioeconomic status. So you've heard nothing new here, right? So if you look at this slide is, I just want to remind you, how does this translate? It translates into things like what happened in Flint, Michigan. It translates into, oops, I was trying to get rid of this thing, mass incarceration, police violence, stop and frisk in New York, they were just stopping people and frisk them. Once you harass people in the street, you're likely to get bad outcomes. Eric Garner, the guy is selling loose cigarettes on the street. The police go to stop him and he dies from his asthma. Right? He would have lived a little bit longer with his asthma, had he not been wrestled to the ground. George Floyd, whatever he was doing, I don't know what he was doing, but the police came and then they put their knee on his neck and he died prematurely. So that's and of course, if you throw somebody in jail for smoking marijuana or carrying marijuana, which is what they did in New York for so many years, those people had shorter lives and poorer health in general. Unequal medical care, the care that you delivered. And I'm going to talk further about that as we go on. Screenings, who gets screening, how much, medical treatments, everything may be the same, but if the treatment you're getting is biased, it's not going to be as good. We see that in pain management, access to drugs, vaccines, access to primary care specialists. Do you think when the rich people, the really, really rich people go to the doctor, they get 5 minute or 10-minute visits? No, they don't. They get half-hour visits. They get the proper visits. And, when I talk to my friends in other places like in the UK or Canada, they're happy in the most part for their socialized care. They so it doesn't mean that you have to have a private capitalist system for people to be happy with their healthcare. The structural determinants of health. So Mary Bassett, who was a health commissioner for New York City and also a health commissioner for New York State, along with Bailey and Feldman, they dug deeply into this, the structural determinants of health inequities, social, economic, and political mechanisms which generate social class inequalities in society. That's the structural part. Structural racism affect both the population and individuals in health in three specific domains: redlining and racialized residential segregation. So I'm going to talk more about that. So this is your housing, where you live. That is probably, in my mind, the most fundamental way in which you're going to perpetuate healthcare inequities. You're going to decide where the people live, segregate them, put them in a Bantustan if you're dealing with South Africa. That's what the South Africans did. They separated the population in two. They put the Africans in what they call Bantustans, and the white South Africans lived in a different area. They would bus themselves in daily to work. That's what that society looked like. That's what America looked like and in many areas today and looked like for most of its existence. People lived in different places. They would come to work in the same place, but then they would separate and go to different places. On the weekends, they would spend their time in different places. They went to separate churches. And of course, mass incarceration is the other aspect of that, and which we're not going to spend any time with, but we touched on, and of course, unequal medical care, which is where we're going to spend most of the time here. So digging deeper into housing discrimination, this was not just a group of citizens behaving badly. This was the entire society behaving badly. The government, in 1933, the federal government established the Homeowners Loan Corporation. This was the government after the Depression saying, we've got to fix the population. So they created a government agency to say, let's help the population recover from the Depression. So we're going to give people money to buy houses. But we're going to find out where the Black people live, and we're going to put a red line around that community because they always live separately, because it started with slavery where they were living separately. Then it went to Jim Crow where they were living separately. So they were always living separately. So it was easy to draw that red line. So they actually had red lines, and that's why I underline red line here. And that's what they did. And if you were in that red line, guess what? You couldn't get a loan from the bank. If you were in that red line, businesses wouldn't go to practices. So what we talk about today that we're seeing has historical roots. It didn't just pop up like that. Somebody didn't just say, we're going to design this today. This is how things evolve, so to say. So how did it end up? Redlining resulted in Blacks being exposed to higher levels of environmental toxin. Okay, you're going to put the factory next to where those red line things are, right? You're going to put the pollution there. Um, uh, in the predominantly white neighborhoods, you have less air pollution, lower levels of airborne carcinogens. You're not going to put your toxic dump next to where the rich people live. You're going to put it next to where the poor people live. Remember, I use the term Flint, Michigan, and so on. And we see these things popping up in the news periodically, and it's almost like a surprise to everybody. It's not a surprise, it's design. Um, Higher exposure levels to toxin create more disease, asthma, low birth weight, and all of that. So pictures of what I just told you about, picture of Eric Garner, picture of the other guy. And let me see if this plays, because this will be my introduction to
This is Democracy Now!,
Can you hear the video?
democracynow.org, the quarantine report. I'm Amy Goodman.
Yes. Yes, good.
As the United States reports world record deaths and hospitalizations from COVID-19 in the final days of 2020, we look at how the pandemic that's ravaged the country this year has shown stark new light on racism in medical care. We begin with a now viral video recorded by Black physician Dr. Susan Moore and posted to her Facebook earlier this month, in which she describes racist treatment by medical staff at a hospital in Indianapolis who did not respond to her pleas for care despite being in intense pain and being a doctor herself. Dr. Moore says she had to beg to receive the antiviral drug remdesivir and pain medication, and accuses a doctor at Indiana University Health North Hospital of ignoring her pleas because she was Black. This is Dr. Susan Moore as she summoned the energy to speak from her hospital bed days before she would die. She had an oxygen tube in her nose.
At that time, I only received 2 treatments of the remdesivir. You don't need it. You're not even short of breath. I am. Anyway, on this thing, you don't qualify. Also because I've gotten 2 treatments. And then it's further stated. You should go home right now. I don't feel comfortable giving you any more narcotic. was in so much pain from my neck. My neck was so bad. Drug addict. And he knew I was a physician. I don't think I was hurting. Oh, God. Taught me one thing. Not much I can do. So I started asking, send me to another hospital where they can treat me. Treat me here properly. Send me to another hospital. Um, getting me up my neck with or without cover. The CT went down a little bit into my lungs, and you can see new pulmonary infiltrate, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward everything. If I was white, I wouldn't have to go through that. The other thing that that white Dr. Bannock said was that if I stayed, that he would send me home Saturday at 10 p.m. in the dark. Who does that? On a weekend, who does that? This is how Black people get killed. When you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody, to let people know how I'm being treated up in this place. And he gladly told me, I know you're a doctor. But he didn't want the Black doctor to have no medicine, nothing. And then the nerve to say, it's because of him, the nurse, that I got the medicine. Really? Because of you? No. How about because I had that stat CT in my neck, where it showed all of that lymphadenopathy and infiltrates? Yeah, you didn't know about that? Didn't get that in report? That's what I said. Mm-hmm. Mm-hmm. It being Black up in here, this is what happens.
Dr. Susan Moore died due to complications from COVID-19 on December 20th, just over 2 weeks after she recorded this video and posted it to her Facebook page. She was 52 years old. Her 19-year-old son, Henry Muhammad, is now left to care for her parents who are both suffering from dementia.
I stop and pause. Did any of you of the group see this video before?
No, I haven't.
Did any of you see this before?
I
No.
heard about it, but I didn't see the video.
Yeah. What's your reaction?
Personally, I've seen how physicians typically treat other physicians when they're the provider for them, and it's usually from like, even if, uh, no matter what, it seems like they typically try to treat them with a lot of respect because they know what it takes to be a physician and what physicians try to do. So, hearing what releasing a patient at 10 p.m. in the middle of the night, telling her that the only reason she's getting treatment is because of a nurse. I can't imagine treating any patient like that, but and the fact he knew she was a physician, still didn't care. It just seemed so blatantly like it's very difficult to hear
Yeah.
personally.
I feel like I was thinking about how she said if she couldn't receive care there, then to send her somewhere where they would care for her. And how in hospitals, when you're in this like desperate situation, a lot of the time, you're kind of just trapped and like at the mercy of whoever's there and whoever is willing to either care for you or not. And so you're very vulnerable, especially if you're in a group that's not going to be cared for properly.
Well, when you get to my age, you end up in hospital beds. And I was there. And very recently, my personal experience was, this was post-op. This was about 6 hours, 7 hours post-op, and I had chest pain. And the intern, first year resident, surgical resident, came to the bedside, and I explained that I was having chest pain. And he spent 10 minutes talking to me about how this chest pain was not likely to be anything significant. Then after bearing that, I said, well, maybe you should do something about it, And he says, oh, I think I'll get an EKG. And then spent another 10 minutes. And then I had to wait till the attendant popped up, a couple hours later, who says, oh, we'll just do some enzymes. Now I taught at that medical school, but I was in a gown. I did not have Dr. Moore, MD, on my ID. I ended up, yeah. Moving. Let's see if I can find my presentation. Okay. Unequal treatment. Racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access-related factors such as insurance and income are controlled. The sources of these disparities are complex and rooted in historic and contemporary inequities. We saw here the doctor had access to the hospital and everything was equal, but she did not receive equal care. She might have died regardless of the care she got. So what are these scientific, where is it rooted? Let's start out with this gentleman to the right, Samuel George Morton, 1799 to 1851. This doctor, physician and natural scientist, that's what they were then, all natural scientists, he collected skulls of the brain, where the brain sits. And he painstakingly measured these skulls and determined that the skull of a white person in America or anywhere was larger in volume than the skull of a Black person. And so white people had bigger and smarter brains. He worked with Glidden, who was probably an archaeologist, anthropologist, something like that, who went to Africa and collected the skulls for him. And you could see to the right those diagrams. They did cranial measurements and so why were they creating this type of thing? They were creating this type of thing because slavery existed back then for about 200 years. And people started pushing back. People all over the world started pushing back. Maybe people shouldn't be born. Maybe this slavery thing is not right. So the argument was, oh yeah, it's natural. It's holy and it's a natural thing. So let's create the science to match it, pseudoscience. If you go to the far left of your screen, you see Samuel Cartwright. Cartwright was a physician, and he wrote in DeBow's Review, which was an agricultural thing. Now, what does agriculture have to do with medicine? Why is a doctor writing there? Because, doctors, the relationship back then was between the slaves did not have a relationship to doctors. Slaves related to doctors through their slave owner. So it was like the way you would treat your pet. You know, you take him to the vet. Well, you take your slave to the doctor, and you as the slave owner would determine what treatment, how treatments, and this was a lucrative business, treating slaves. It's, you know, veterinarians do quite well. So he created all kind of diseases, dysesthesia ethiopica, that's heavitude of the mind and intensity of the body. That's where the slave walks around, and instead of being at attention and acting like a soldier happy to do the work, they're kind of like, you know, walking around lethargically. Maybe they were sick, but didn't matter. You know, if they weren't moving fast enough, then you just whip them back into shape. And I mean literally whip them back into shape. Dirt eating, slaves eat dirt. You know, that's a natural thing. And remember now, so they created, so these diseases belong to the slaves, you know, drapetomania, that's a tendency to run away. They keep running away. They must have drapetomania, drapetomania, I'm sorry. So this is scientific racism is a racial biology, a pseudoscientific belief that empirical evidence exists to support and justify racism. The gentleman to the top, Josiah Clark Knott, his statement was the Negro achieves his greatest perfection, physical and moral, and his greatest longevity in the state of slavery. And my favorite is the one in the middle, Louis Agassiz. So Louis Agassiz was Swiss-born, and many of them, you know, who believed in eugenics. That's the science that one race is better than the other, and we should work towards improving mankind by improving a particular race. So Louis Agassiz came from Switzerland, came to Harvard as a biologist and distinguished scientist. So when he got there, he met Black people for the first time, and he was fascinated. So he heard about Martin. So he went to Philadelphia, where Martin was, and then he saw all these slaves. He was so fascinated that he took photographs. Now, earliest photographs back then were daguerreotypes, and I show you one of them there. I just, usually I have a much larger, but for this group, I'm just showing you those two photos. If you notice the way, this is 1850, around 1859, 1850, between 1850 and 1859. You see the woman, she's half naked, breast out. People didn't dress like that back then, but if your slave was just like your dog, you don't put clothes on your dogs. So I'm being graphic here, but I'm showing you this was the relationship. You know, you beat the person if they're not behaving a certain way. You dress them anyway. You take photographs of them naked because that's the way that was. Let's start off with the one in the right bottom of your screen. This is Atabenga. Atabenga was from the Congo. And this gentleman next to him, Philip Werner, he was somebody who went to different places and collected exotic animals and brought them back for display in museums and so on. So he brought back Atabenga, whose family was killed, you know, by one of the colonial companies. And he brought him back, and he started displaying him in various museums. He took him to the Bronx Zoo. Many of you have heard about the Bronx Zoo. I grew up close to the Bronx Zoo. I grew up in the Bronx. Went to school not far from the high school. And he put him on display with the chimpanzees. That's what they did. This was 1906. This was not 2,000 years ago. This was not 100. This was just a little over 100 years ago. George Marion Sims at the top. Well, most of you have probably heard about Henrietta Sacks. I won't talk about, but this is just how her cells were. Everybody made money off her cells, and she and her family lived without insurance and died in poverty. So the big photograph with the group that looks like a graduating medical class, which they are, of Georgia, uh, um, has a photograph with a person at the top that's circled with my white circle. That's a Black man. What's this Black man doing there? I love to tell this story. So the doctors, the professors at the Medical College of Georgia needed cadavers for their students. So in about 1850 or so, a little after that, they hired this slave, not hired, bought this slave, big, strong man, and they said he was going to be a porter, but his real job was to be a resurrection man or a resurrectionist. His job was to go dig up the recently buried bodies from the cemetery and bring them back to the medical school. So he did that, and he did it very well. Um, he 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 was a curious guy. So he just didn't like bring the bodies. He got involved with the students. He was a friendly guy. So they taught him. They taught him to read. Remember, slaves at that point could not be taught to read. They taught him to read. And the reason they taught him to read is so he could read the obituaries to know where the bodies were. And then you had to go read the tombstones, right? So you had to be able to read. He couldn't dig up old dead bones. He wanted fresh bodies. So after he did this for a few years, right? 1956, I think. So after a few years, then the Emancipation Proclamation. So here it is. You've got this Black guy who's been hanging around with the doctors and the medical students. He's really smart. So he goes to the next town and becomes a judge, right? Because, right, this is Reconstruction. So now he's a judge and he's doing well. But of course, as you know, within 10 years, all of this Reconstruction business, they, got rid of it, and they started instituting Jim Crow laws. So they kicked him, from the judgeship, and he goes back to the Medical College of Georgia, gets its old job back, and goes back to the resurrection thing. But, again, he was like a mascot, so he would get his picture taken. I think it's a fascinating story. The way we know about this story is because a book, when they were doing some archaeological work at the Medical College of Georgia, they dug up into this basement and found all of these bones. So the construction people reported that to say, hey, we've got all these bones here. This is a crime scene, whatever. So they came and they said, no, this is an archaeological scene. And they went back, they traced everything back. They went back and did the oral stories of the people from the neighborhood. And they told them about this guy. His name is Grandison Harris. And he was a man about town. So, the story here is the story here is the bodies. When Black people are afraid of their bodies being used for science, it's got good reason. Bodies were dug up in every town there was a medical school, New Haven, Cambridge, but that was one story where we have actual good documentation. So many of you have heard about this, the syphilis experiment in Tuskegee. Two things I want to say about that. When they do these things, these are not white people going into a Black place and perpetuating these atrocities. The way it's done is they find trusting Black people like myself, send us into the community where we're trusted, get the people to do. The reason why I do all of this now, and the reason why I even know all about this, is because I was asked to do this work. I was asked by Presbyterian to go into Brooklyn to recruit people for their anticipated NIH cancer center in Brooklyn, where all the people lived, right? They had all of these centers they had Manhattan taken care of, but they needed to go to the population. And, here it was, we have a Black doctor amongst us, we'll send them out. So I said, well, I knew about how this works. So I said, let me study how I don't become an unwitting person in all of this. So the person you're looking there is Eunice Rivers. She was the Black woman that went into Tuskegee that had the trust of the people and got them all to participate in this study. Yeah, if you look at the poster, it says colored people free blood tests, free treatment. See, it says treatment. I don't know if this was a made-up flyer or this is a real flyer. I got it off the internet, and it has the phone numbers you call and come by. But this was, this was a real study that they were planning to do when Booker T. Washington back at the turn of the century met with Rosenwald, who was from the Sears Roebuck Company. They decided we needed to take care of people in that area. They had poor access to care, whatever. And this was a plan to go in there and take care of the disease. But the United States Public Health, when the market went bad and they didn't have the money, the United States Public Health Service decided to take it over. And there were racist people within that who felt, well, we need to make an experiment out of this. So they lied to the people. They took them to the VA hospital where there was a black doctor, Dr. Dibbles. And so the black people were fooled into we're going to be taken care of. And that's how that experiment started. And everybody knew it. Everybody in the society, when I say everybody in the society, I'm being facetious here. The AMA knew about it. This Tuskegee study was reported to the AMA multiple times. The doctors knew about it, but they sat silent. The black doctors weren't members of the AMA at the time. And because we couldn't be because we couldn't be members of the county medical societies, which is how you get to the AMA. So that's why I participate in all of this. I need to know what's happening. So the county medical societies didn't admit black doctors, so black doctors didn't get to the AMA, but the white doctors knew about this study. It was reported to them. It was being published, but they allowed it to happen. And then, in 1972, when the reporters broke the story, everybody was sort of like, we didn't know, we knew. Just moving quickly here, experimentation in prisons on black skin. Retin-A, that guy Kligman, he was the one who developed Retin-A, was developed from prisoners. A lot of the stories I tell you is from the book Medical Apartheid by Harriet Washington. She broke that whole story about kidney transplant and all of this. So here's a good example. So are we done with this? Are we post-racial? Is everything cool right now? All right, so I'll tell you about this because this is my history here. This occurred during my time. I'm in practice and I'm being drug company reps come to my office and they say, we got a drug here for black people. It's called Bidil. Bidil was scientifically approved for heart failure in self-identified African-American patients by the US FDA in 2005. So, I'm fully in practice at that time. I was probably even taking insurance at that time. And they said, this drug, the AHEF study, demonstrated that Bidil improved survival and reduced hospitalizations in African Americans with heart failure. All right, so it sounded good. NAACP lobbied for approval and promotion of Bidil. The Congressional Black Caucus lobbied for approval and distribution of this drug. Scholars, the ABC, African American ABC, basically the Society of Black Cardiologists, right? They were upfront. Yes, we finally get a drug for black people, but it didn't work. It didn't work because this was a drug that was being prescribed to everybody already, right? That run out its patent, hydralazine, which was a drug around for a long time, and nitrate, which is isosorbide dinitrate. So what these smart entrepreneurs did, they realized that black people responded better to this particular combination than the rest of the population. So they then put the two drugs into one pill, went to the FDA, got approval and said, this is ideal for Black people. Here are the studies. And the FDA went along and they created this drug and they put it out. But then there were people that were around that knew history and had their wits about them and said, this is not right. You know, first of all, this study you did was just done on Black people. Why didn't you put white people in the study? Why didn't you put other people in the study? Why did you just do a study on Black people? You know, we don't do medical things like that. But because it was for Black people, it was okay to not do it scientifically correct. Race-specific approval spurred discussion about racialized medicine, and that's what I want to introduce here. If you see anything about racialized medicine, you should run away. There is no such thing as racialized medicine. Race is often understood as a social construct. So if we're going to talk about personalized medicine, then we're going to talk about certain demographic characteristics. And those demographic characteristics should include things like your age, right? Demographic matters, right? If I give a baby a drug, it's going to be quite different with respect to pharmacokinetics, with respect to distribution, and everything we want to know about a drug is going to be different based on your age. Based on your sex, there are going to be some differences, but based on your race, well, based on what I told you, remember, scientific racism says there was a difference. But the anthropologists did all the studies and showed that there was no difference. When we mapped the human genome, we showed there was no difference. So there was no scientific basis for race. This was a construct that was created for political reasons, is that it was not biology. It was not genomics. It was not genetics, but they were conflating race with genomics and genetics. And so there were people arguing against this. But remember, the first thing I pointed out was that the Black organizations all jumped on board because they were not informed. And there were Black scientists who were also not informed. There were some that were, but the noise and the momentum and the racism that existed in the society. Remember, racism is not peculiar to a particular race. All races, and race is a real thing, all races are racist. All individuals are racist. I am racist because I live in a racist society. So the idea is, so I can easily be led into a racist situation because of everything that surrounds me. So race is a social construct and not a biological one. There are correlations between race and certain biology, but if you compare if you compare individuals within the same race, if you compare the genetics of individuals within the same race, there's going to be more variation of individuals within the same race than you would find if you use race as a distinction within, then there will be more variation within the race than the various different races. Let me try to say this in another way so it's clear. So between me and another Black person, another random Black person, you're going to look at our genome versus me and somebody of Asian descent. There's going to be more variation between my genes and another Black person's genes than you would find in general between me and somebody that lives in Asia, that is considered Asian. That is not a real biologic distinction. So when you create drugs for a particular race, you're making a medical mistake. And this was this century. Idle was this century. So racialized medicine, which is what it is based on racial essentialism. I'm sure Marvin is going to show you a lot of instances of racialized medicine when he shows you the comparisons between the races. So when we're looking at these comparisons, we're not looking at biology. We're looking at the social determinants of health. we're looking at socioeconomic status and we're looking at racism. That's what makes the difference, not the biology. And what Susan Moore, who is no relationship to me, what she was saying is, even though I'm a doctor and I'm of the same socioeconomic status, I have the same education as the doctors. And even though doctors give each other professional courtesy, I don't get any courtesy because I am Black. Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. That was Martin Luther King. So as I wind this down, segregation is separate and unequal facilities. Basically, that's how we do this. We do this by putting people in separate buckets and private versus public hospitals. There should be no public hospitals. There should be one hospital, a non-profit hospital. There shouldn't be public hospitals. There shouldn't be private hospitals. There should be non-profit hospitals. Once you have that distinction, public hospital, that's where you put poor people and treat them poorly. If you have private hospitals, then you can keep people of lower socioeconomic status out of your hospital. Jim Crow hospitals, the way it existed for most of the 20th century, they would have a thing called a hospital, then they would have a white entrance and a Black entrance. They would have white wards and Black wards. So if the population, say, was 50-50 in that town, 90% of the hospital beds would go to the whites, 10% would go to the Blacks. They would lump all the Blacks in that 10%, whether they're delivering babies, whether it was a gunshot wound, they would put them all in the same place. They wouldn't have Black doctors to treat them. The white doctor would treat them and they would treat them poorly. That's how medicine existed for the entire, for the first part of the 20th century. And I'm saying it still exists today as long as we practice racialized medicine. Health insurance. Most of my practice, remember I told you I dropped those insurances, the HMOs. I wouldn't participate with them because the HMOs were bad care. PPOs was another way of making it better. You don't need these separate insurance companies. In the 2003 study I showed you on equal treatment, fragmenting the healthcare system into different insurances is a way to do this. If you just have one insurance, then you have eliminated a way of doing that. Providers, Black doctors in the South were denied hospital privileges, which I told you about until the mid-60s. The way we treat our patients, the private patients come to your office, the public patients go to the clinic. And, I had a situation where I'm referring a patient to my favorite gastroenterologist, which I see as my own doctor. When I tried to send a patient, he says, "Oh, I can't see that patient in the faculty practice. I can see the patient in the clinic." It was a matter of insurance. We know some of this from the book, The Good Doctors. Just as we close, why should you care now? You're a doctor, you'll maybe not be Black, so why should you care about this? Well, Martin Luther King again says, injustice anywhere is a threat to justice everywhere, right? So if you allow it to exist, eventually it's going to catch up with you. What do I mean by that? It's catching up with you now. You see what they're doing in Washington. First of all, this is the first step. What they're doing is they're eliminating people on Medicaid, right? If Medicaid didn't exist, you couldn't just take away insurance from all of those people like that. But you already had them categorized. You already put them in the box of Medicaid. So you can eliminate that box right then and there. If it was a single payer insurance, and I'm a single payer advocate, obviously, then you couldn't do that. You'd have to find some other way of doing it. So I'm just taking away the tool. Healthcare is a right. We all have that right. So they're saying, okay, we have the right, but we'll give you a separate, an unequal right. No, we want the same right for everybody. Institute of Medicine, from an international perspective, says Americans as a group have shorter lives and poorer health. The reason is because we have, Donald Trump and Elon Musk, they don't have poor access and whatever, but the majority of the American population does. Maybe not the majority, but a large chunk of the American population. So what we want is equity. That third part there I showed you before. So you can't spend enough. No matter how much you spend, you can't solve that problem because we're already doing that. We spend more than everybody else. And this is I said earlier, that's about 20% now, and not just 16.6, but the data stays behind the reality. Health equity. So that's what we should strive for. Equity means that everyone has a fair and just opportunity to achieve the best possible health. This requires moving obstacles to health, such as poverty, discrimination, and their consequences. So it's not just poverty. You can't just give people money. You've got to take away the racism. Because that's how you discriminate. Racial discrimination results in the feeling of powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. So, advancing health equity by addressing the social determinants of health. Elizabeth Bradley, who I had the good fortune to meet while she was dean at the public health school at Yale. She points out in her article in 2013 that residents of nations with higher ratios of spending on the social services, that's that 30% that I showed you, to spending, well, that's at 15%, 15 plus the 5%, so that's 20%, 25, let's see, I said 10%, right, that's the 20%, but 15 plus the 5% of, if you spend the money there, you're gonna get better outcome than if you spend all of it on the 10%, which is the medical care. So they're saying that societies that spend there are gonna improve their outcomes. And I showed you the outcomes are measured by infant mortality and maternal mortality. So those are the numbers we keep looking at. And you already see that those numbers are declining. So it means we're doing poorer. So from 2013 to now, our health have gotten poorer. Our mortality has increased. And you can check me on that. Our mortality has increased. We're dying earlier. The best available evidence suggests that health policy framework addressing social and behavioral determinants, right? I showed you that behavior would lead to better population health, reduce inequality, and lower costs compared to our current policies. So payment systems, and this is, I guess, for this group, payment systems should avoid fragmentation into health plans along socioeconomic lines. So we should eliminate Obamacare. Period. It shouldn't exist. Why do you need Obamacare? You just need one insurance for everybody. Obamacare was to put a group into, you can eliminate Obamacare by just, all the people on that insurance by just eliminating Obamacare. So why do you need it? So that's why that group exists. It's segregation. You don't need Medicaid. You should eliminate Medicaid. You should have one insurance for everybody. And don't take your Medicare and chop it up into privatized groups, because that's just going the wrong direction. There should be no Medicare advantage. So the racism part, we're all racist. So we should look at our biases and try to eliminate our prejudice and recognize that it's not just up to us. There are structural processes in place that creates racism. I'll share this entire thing. These are my sources. And not all the sources, unfortunately, I didn't have the time to compile everything. So I'm going to end here. Thank you very much for your attention.
Donald, thank you so much. I really appreciate you taking the time to join us. And we're going to take a 5-minute break, and I'm going to show some slides at that point. And Donald, if you don't mind staying. And,
yeah, I absolutely will stay.
Yeah, I'm expecting questions after the slides. So let's reconvene at somewhere around 10:22 or 10:23, and we'll take it away at that point. All right. So I appreciate Donald Dr. Moore giving us this intro. And I'm just going to push the discussion a little further, discussion of race in the healthcare system, with a bunch of slides I compiled, which ChatGPT and I put together yesterday. And here they are. All right. So this discussion will be on disparities in health and in healthcare in the United States. And the majority of these slides are from 2022 or 2023. So these are current data. And before I do that, I just want to show this slide. This is a slide that depicts campaign contributions among doctors. And what you're seeing that back in right up until the year 2002 or 2004, doctors were giving the majority of their campaign contributions to Republican candidates. Doctors were conservative, on the order of 65% or so. And that began to change in the 2000s. And then starting in 2015 or so, it's changed even further. And now doctors are giving primarily to candidates in the Democratic Party. And to me, this is just one manifestation of the fact that we've changed. We've changed from one era, which I've called the Reagan era, to the next era, which at this point, I guess we can call the Trump era. At any rate, now the doctors are in the Democratic Party, they're liberal. So all this racism stuff you've been hearing about from Dr. Moore probably doesn't apply anymore, because now we're all liberal in the doctor community. So I wanted to see if that's the case, and so came up with some slides. So here's a slide showing life expectancy by race. And what you're seeing here is that life expectancy among white Americans is 78.4 years. Among Black Americans, it's 72.8 years. And that may not sound like much, but on the International Life Expectancy list, that puts Black Americans just ahead of Venezuela, but we're still behind Uzbekistan, Iraq, and El Salvador in life expectancy among the Black population in the United States. A little bit embarrassing. And so here's a slide on mortality rate, and you can see that total mortality rate is higher among Black Americans, and that goes along with the life expectancy expectation. However, there's another statistic that can be calculated called amenable mortality or preventable mortality. And these are conditions where a death, just with better medical care, a death could have been prevented. And what you can see is that preventable mortality rate is nearly 108 deaths per 100,000 among Blacks, but only 84 per 100,000 among white population. So that's the medical care part of it. And earlier in this internship, and as well as today, we discussed that medical care has an effect, but you can see that this suggests that there is an issue within the medical profession itself, because these are medical treatment amenable deaths. And the data are the Commonwealth Fund. All right, so here's another statistic called years of potential life lost. And in this statistic, in case you've never heard of it, you pick a year, and this chart is done for age 75, which is a common year that's used. And what years of potential life lost means is that by age 75 means that if you die at age 74, you have 1 year of potential life lost due to some factor that impaired your life expectancy from what you'd expect to be 75. On the other hand, if you die at age 10, that would be 60, you would count 65 rather than 1. So in other words, this statistic is trying to weight heavily deaths at a young age because the total mortality is heavily impacted by deaths among elderly people. So this does the opposite. It overstates and emphasizes that a society is having many young people dying. And you can see that this difference in mortality is much greater for Black Americans than it is for whites, 25% greater. So many Black people are dying earlier decades of their lives. And I'm not explaining the data. We can do that in our discussion afterward. I just want to present it at this point. So here's some data on diabetes. And what you're seeing is that the prevalence of diabetes is considerably greater among Black Americans. Those are the left two bars, 16.8 percent among Blacks, 16.8% have diabetes among Black adults, and among whites, it's only 11.2% of the adult population. However, if you're looking at poor control of diabetes, which is the second set of bars, you're seeing that poor control is vastly more common among Blacks, that 102 out of, and this one's looking at admissions for uncontrolled diabetes where there's nothing else wrong. They don't have pneumonia causing the diabetes to be out of control. The control of diabetes was just not done well. Whether it's due to the patient not paying attention or the doctor not explaining things well, or the patient couldn't afford the medication, or the doctor's making the wrong decision about which medication to use. It's not, you don't know that. All you know is that 4 times more Black people come to the hospital with uncontrolled diabetes as the only reason they've come. It's a very striking difference. And here's a difference in hemoglobin A1C, which is a measure of long-term diabetic control. And this may not look like much, but 0.8% difference in hemoglobin A1C, which is what you're seeing here, is actually quite large and predicates a whole lot of extra mortality. And to the credit of the medical profession, the primary care sector where diabetes is primarily treated, yeah, Black people have more diabetes and more uncontrolled diabetes. So it's nice to see that there are more annual visits per diabetic patient in the United States. So this presumably reflects some progress, while the second set of bars suggests that we have a long way to go. And it may take more of a differential number of visits. And you know, for a lot of these charts, I've looked up the relative contribution of socioeconomic status to these disparities, and it is strong. It is strong that poor people, if you did the second set of bars for just poverty, based on poverty, people who are very poor would have many more hospitalizations for uncontrolled diabetes as well. So but there's a long way to go for to achieve improved control among Black and, for that matter, poor people with diabetes. Same thing for hypertension. Prevalence is much higher among Blacks. And then uncontrolled hypertension, which is very lethal. It's the biggest risk factor for stroke. It's more common in Black populations. And then overall blood pressure control, this is probably not as reliable a statistic, but a 4 mm difference in systolic blood pressure control when applying to millions of people actually will lead to many more strokes. And in fact, a little later in the slideshow, we'll get right to that. So if you're having more hypertension and more diabetes, what you'd want to see is more primary care visits. And what you're seeing on this slide is that even though Black Americans have more issues with hypertension and diabetic control, and at least we're getting diabetics in more to primary care centers, overall access to primary care by race is something we have not achieved equality yet. And here you can see that based a measurement of the number of visit minutes per year per Black adult is only 52.4, whereas among white Americans who overall are healthier, they'll spend 70 minutes per year on average in the office with a primary care practitioner. This is actually in the office, not in the waiting room. In terms of percentage of white Americans, 89% have a primary care provider, and whereas among Blacks, it's 86%. So somewhat less. I think if you would have looked at this 30 years ago, the difference would have been really, really great. So that may be one that we've improved. And on the second day of this internship, you learned about the Community Health Center program. And that program was essential in getting this statistic to be as good as it is. Although it's not, we're not at equality at this point. So you look at specialty visits, you can see that overall, Black people are only 27% as likely to see a dermatologist. And dermatologists do treat a lot of very elective, more cosmetic kinds of things. On the other hand, Blacks in general have worse access to specialists in general. So general surgeons treat a disease like appendicitis, where the presentation to doctors would be pretty close to equal by race. But you can imagine a condition like varicose veins or hernia, an elective hernia that the patient's had for years. And Black people don't end up getting visits as often as white people. In fact, it's dramatically different, 45% less. And same for orthopedics, for treating a lot of what orthopedics treats are chronic arthritis. And Black people just may kind of not end up seeing a specialist just because their access to the healthcare system is different from white people. And even though Black men have a lot more issues with prostate disease, they're actually seeing urologists less often than whites. So then over on the right, if you look at the two specialties where Blacks have greater access, the fact that they're seeing nephrologists 2.78 times more than white people is not exactly a triumph for the American healthcare system. This is because if you're looking at the number of visits, people who are on dialysis have huge numbers of visits. They usually show up 3 times a week. And many, many more Black people are on dialysis because all the efforts of the primary care sector and other parts of the healthcare system to effectively treat hypertension and diabetes and prevent end-stage renal disease, especially from hypertension and diabetes, they're not working out well for Black people. And so there's a whole lot more end-stage renal disease among Blacks. And this slide reflects that. And among hematology, it turns out that myeloma is a good deal more prevalent among Blacks, and as is sickle cell disease. So that all ends up going to hematology. Anyway, so that's kind of a profile for specialty visits. Now we'll turn our attention to infant mortality, which Dr. Moore mentioned earlier. And what you're seeing here on the left set of bars, infant mortality rate is a good deal higher for Blacks. It's more than double the infant mortality for whites. And Dr. Moore pointed out that this is a better reflection of the society as a whole, ranging from the healthcare system to social inequities. And this sort of gets boiled down into this huge discrepancy in infant mortality rate. And here I just want to say that as a percentage of population, whites are almost 60% and blacks are just under 14% currently. But if you're looking at prenatal care, early prenatal care, who gets into prenatal care early in pregnancy, which is your goal? White people get in 79% of the time, whereas among blacks, it's only 66%. And then the average number of prenatal visits, if you compare black versus white, you can see that white people have more prenatal visits, despite the fact that our prenatal care system should be focusing on black patients, where we have this massive discrepancy. And this is 2000, these are 2022 data, but I went back to 2000. Actually, let me present maternal mortality first. Same thing with maternal mortality, although on that left bar, the maternal mortality rate is massively discrepant, even more so than infant mortality, with a maternal mortality rate of literally 70 deaths per 100,000 pregnant patients who are black, whereas among whites, it's 19. That's a massive discrepancy. And then early prenatal care and average number of prenatal visits, that's just the same as the other graph. So you can see that whites are accessing more obstetrical care during the prenatal period. I just went back to 2000 to also come up with the maternal mortality rate. And this bar is frighteningly similar to the one from 2022, this bar graph. You won't even know there was a different year. So what this is showing is that 22 years have gone by and we kind of haven't accomplished very much. So for those of you who are going to go into OBGYN, we seem to have a ways to go. And again, I admit a lot of this is social determinants of health, all the factors that lead to maternal mortality, which we can discuss later. So the question is, are these unfavorable obstetrical outcomes among blacks explained by race or income? And what it's shown is that black infants and mothers, regardless of income level, have significantly worse health outcomes compared to their white counterparts. Babies born to black mothers in the highest income brackets are more likely to be premature and have low birth weight than white mothers in the lowest income brackets. Pretty shocking statistic. Infant mortality rates among babies of high-income black mothers are comparable to those born to low-income white mothers. And in terms of maternal mortality, high-income black mothers face a similar risk of dying in the year after childbirth as the poorest white mothers. And as we've discussed many times during the internship, poverty and lower socioeconomic status are powerful predictors of health, virtually all health outcomes. So it's disturbing that this benefit doesn't seem to accrue to black people. All right, we'll look at some geriatric data now, joint replacement by race. And what you're seeing here is that the middle bars are the population again, so that gives you a sense of the ratio of whites to blacks in the overall population. But on the left are hip replacements, and on the right are knee replacements. And these are a product of our healthcare system, because I can assure you that rates of advanced arthritis are not better among the black population in the United States than they are among whites. What this is showing is that white people have better access to an expensive surgical operation to deal with end-stage far advanced arthritis, both when it comes to hip and knee replacements. So this is a glaring disparity, actually, in care. Twice as many whites, blacks are 13% representation in the population, but only 5 or 6% in terms of access to joint replacements in the US. And this is 2019 data, I think. They compiled a study over several years. And here's disability prevalence by race. By the way, the knee arthritis and hip arthritis are major contributors to permanent disability or long-term disability. And you can see that this correlates with the fact there's a whole lot of advanced arthritis among Black Americans. 25% of Black Americans have a major disability, whereas it's only 20% among white adults in the US. All right, so finally, or the last two areas are vascular disease. This will be next. And so if you look at stroke mortality, so the middle bar is percent in the population. That's just an overall population statistic. Whereas the stroke mortality rate among Blacks in the left two bars is considerably higher, a full 50% higher at stroke mortality rate among Blacks is considerably higher. Now, most strokes are ischemic, meaning there's a blockage to the arteries that feed the brain. And since you've all studied anatomy, it starts out being the carotid, which is a branch off the aortic arch. It heads into the brain and then becomes the cerebral artery and feeds the entire brain. Okay, so while it's the carotid artery in your neck, a heavy cause of these, direct cause of these strokes are cholesterol globs blocking up your artery to your brain. So in the healthcare system and primary care, you could potentially detect an obstruction due to atherosclerosis, and you could bypass an artery that's pretty blocked up with cholesterol and hopefully prevent stroke. And so there's a whole bunch of criteria for who should get a carotid revascularization. But when you actually look, even though the stroke mortality among Blacks is a good deal higher than it is for whites, are we trying to pick up carotid disease early and accomplish revascularizations in Black patients? And what you're seeing is that compared to the population percentage of Blacks in those middle bars, Black Americans are not accessing carotid revascularization at all, hardly. And this, is the medical part of our, quote, contribution to this disparity in stroke mortality between the two races. So here's coronary disease. And what you can see is that, once again, the coronary mortality rate among Blacks is higher, with a mortality rate of 210 per 100,000, whereas among whites, it's only 160. So Blacks are more likely to die of coronary disease. But when you look at revascularization, Black population has just a little bit more access to revascularization. So it should be 25% higher, which then would correlate with the coronary mortality rate, and it isn't. However, this chart is actually kind of a triumph compared to most of the rest of what I've shown you. Because within the field of cardiology, there's been a focus on getting women and racial minorities into access invasive cardiac care. So this is a whole lot better than what we saw for carotid revascularization, where Blacks at least have some access to care, they're getting treated, and that disparity in coronary mortality rate shown on the left presumably would be a whole lot worse if we hadn't started our getting our act together to actually help our Black patients have access to invasive coronary care. And, many forms of invasive care are not going to affect mortality very much, but the coronary artery angiograms, stenting, and bypass actually have had unusually great effect compared to many types of interventions. They really are successful often. And in the picture on the left, this is a patient with substernal chest pain. This is commonly where chest pain is located. when you're having a coronary event like a heart attack. But I just wanted to clue you in, since you're medical students, your chest actually does not turn red when you're having a heart attack. Just so anyway, that doesn't happen, but you do get chest pain much of the time. All right, so then there's lower extremity vascular disease. In other words, you can get cholesterol globbing up arteries that feed your legs, just the way it can happen in the carotid arteries to your brain and in the coronary arteries that feed your heart. So in other words, the iliac artery, the femoral artery heading down into the legs, they can be blocked up too. And if things get bad enough, you can end up with such inadequate, insufficient blood supply to the lower extremity that you become severely susceptible to infection from even a minor little cut. Can be very painful, and especially when you attempt to exert yourself and walk even on level ground. So, but amputation is vastly more common among people who have cholesterol globbing up the arteries to feed their lower extremities. And similar to carotid procedures and coronary interventions, you can intervene and do a revascularization of the lower extremities. So on the left is the amputation rate by race. And this is, to me, one of the most shocking disparities of any of the data you've seen so far. I mean, that fellow in the picture doesn't look too unhappy. Fellow with a right, what appears to be a right below the knee amputation. I think below the knee. Anyway, but this is a powerful, powerful disability to spend years of your life without a lower extremity. So the fact that there's an amputation rate that's literally just 3.6 times higher for Blacks should be regarded as an absolutely astounding major public health failure and a real failure in the US healthcare system as well. Okay, so with all those amputations, meaning there's advanced peripheral arterial disease among Black populations in the United States, you expect that there would be more revascularization. But would you be correct about that? No, you would not be correct. That in fact, whites have 2.5 times more lower extremity revascularization procedures compared to Blacks. This chart is hardly a triumph of any accomplishment in our healthcare system to eliminate disparities. This is, to me, really, really shocking. And finally, we're going to talk about cancer. So people with brain tumors showing up on their CT scans. So on the left side here, you're looking at cancer mortality rate by race. And what you're seeing is that there's about a 20% greater cancer mortality among Blacks in the United States compared to whites. So there's sort of different kinds of surgery that can be done when you have cancer. One type is palliative, where the cancer's advanced and you're just sort of reconnecting a bile duct. You're not going to cure the cancer. The patient might die 6 months later. Or you could say, well, we're going to try to cure this. We think we can get all of it. So despite the higher cancer mortality rate among Blacks, here's another shocking disability. There's more than a 3 times greater likelihood that a surgeon is going to do cancer surgery with curative intent among whites compared to Blacks. This is another really shocking disparity in care in the United States. And I will leave it there. And we're over time, unfortunately, but we're going to start our next session later than what's scheduled. So I think we have at least till 11 o'clock or so, or maybe even a little more if you guys have questions. And then we'll start our next session at around 10:15 or 11:15, sorry. So anyone have questions? I did find these data a little depressing, but anyway. Dr. Moore, do you want to make any initial comments before the students chime in here? You're muted, I think.
Yeah, I was gonna say, just since their hands up, why don't we just go to that?
Okay. Zach, what you got?
As you just illustrated, it seems like um, it doesn't seem like there is like institutional racism in the medical industry and the practices of medicine. And this is for, I guess, Dr. Moore, but also for you, Dr. Malik, if you had thought about this. I know in my own practice, I'll have to like be consciously anti-racist, and I don't know how I'm gonna do that at this point in my career, but I'm sure I'll figure out along the way by asking physicians how I can practice and try to limit health inequities with my own patients at least. But how have you, if at all, found any um, way to help patients overcome the institutional barriers to achieving equitable health outcomes in your own patients? And I know we can advocate for like abolition of some of these like healthcare systems that perpetuate inequities, but aside from that, is there anything we can do for our patients specifically to help them navigate the healthcare system if they're minorities? And then is it even reasonable to try and put the impetus on our patients? Like, is that too much to ask of them um, in achieving like health equity? I, I, I just
Donald, you
don't,
take.
it seems like a big task and I don't know where to start.
Yeah, I'll take a stab at that. Uh, I guess because of where I am in life, I can speak from my own experiences. So when I left medical school, or certainly when I was applying to medical school, my thoughts were that I was just going to do the best uh, at being a doctor. I had no idea what doctoring was. I had no experience with doctor. As a young person, I never went to doctors. You know, my mother was a nurse, and she was a skeptical person. She was very involved. She was an activist in nursing, but she was skeptical of medicine, and it probably was her life experiences. So once I did get into medicine, and as I was going each step along the way, there was something that I kept seeing. I kept seeing the disparities. I kept seeing the inequities. And a lot of it was really not even having to do with medicine, just having to do with life. So when I became a doctor and I was in control, I got to drive the car. I had choices to make. I could make more money, or I could put everything into being the best doctor. Maybe this is something I got from my mother. She didn't seem, she always did the best for all of us, but I think she was just the best nurse that she could be. And being the best doctor meant that I didn't always, I had to suffer consequences. You know, I was in a surgical program at Mount Sinai, and it was a racist program. They were doing bad things to me and to the patients. And I spoke up. I fought back. And you can't, if you fight back, you're going to get hit back. You know, when I was at Kings County Hospital, a city hospital, I thought things would be better there. It wasn't. It wasn't until I got into my own practice where I was more in control. But at that point, I could have aimed towards seeing more patients because I had no control of reimbursement, but I had control of how much resource I'm gonna apply to each particular patient. I took the position with most every patient that every patient was compliant, meaning uh, I lost the definition of non-compliance. To me, there was no non-compliant patient. Every patient, if the patient didn't agree with me, then I changed the approach, you know. So if I said, you take this medicine, and they say, I ain't taking that medicine because, whatever, then okay, then we start there. And I watched my mother do the same thing. At 70 years old, she was diagnosed with end stage, not end stage, she was diagnosed with heart failure, high class heart failure, maybe class 3, where you're going to die within 5 years. And the doctor said you're going to die within 5 years. And she says, well, I won't see the doctors anymore. And that was her approach. She did that 40% that I talked about, didn't drink, didn't smoke, didn't, did all the good things. I didn't see her doing a lot of exercise, but she did everything there. She couldn't change the genes. She took the medicines as she, as a nurse was trained to do, and she went on 15 years. So you're going to be in whatever field you choose. You're going to be in control of how you as an individual operate there, whether you're in research and whatever. And there is bad research, and there are times for you to speak up. If you're an administrative person, you're going to get bad instructions. And if you don't follow those bad instructions, you're going to get pushback. But you're going to live and you're going to do well as a doctor because you have gotten this far. So I think the personal choices, what you're told. I was part of a lot of these things. As I said, I was part of that Bidal thing where and then I later found out it was a mistake. I was part. Certain things sort of didn't sit well with me when they were telling me to assess kidney disease as with Black people differently. It didn't seem right, so I didn't do that. And a lot of my intuitive decisions were right. Don't do that kidney disease thing. Don't assign Blackness to heart disease. And so whatever the standard for the white people were, I just applied it to my patients. I applied it across. I didn't put race standards in there because it didn't make sense to me. So I think this is the group, this is a choir. So you guys are doing the right thing already. You're doing something outside of the standard medical training. So there is no specific answer. You're not going to convince somebody who's been beaten up in, in housing and everything. You're not going to convince a lot of people to take a certain medicine, but you can meet the patient where they are and give them the best care. If you know it takes more than 5 minutes, don't give them 5-minute visits. Give them whatever length of time that it takes. So that's, sorry, that's the best answer I could give.
I'll make a stab as well, because it's an important question. At the system level, I totally agree with what Dr. Moore said earlier, that in the US, and probably in most countries, but say in the US, if you create more than one category, Black people will somehow end up in the category that gets worse medical care. And that's a big reason you're seeing this. If there's Medicaid, which many doctors don't accept, or the category of having no insurance at all, those categories, Black people are overrepresented in both of those categories and underrepresented in other categories where, patients do better, get more care, better care. So creating two-class systems is not going to help Black people in general. So fighting the economic battle is important about inequality. But I just want to say something at the extreme opposite level, at the individual level. If you make eye contact, even with a 90-year-old Black woman who has dementia, don't treat that person as if they don't exist and talk only to the daughter or the son. Make eye contact with every patient, talk to every patient with kindness, with a smile, and explain things. Ask the patient to repeat back the important points to make sure they understand it. Just be decent. Treat patients the way your mom would want to watch you, see you do it. And just don't forget that make eye contact and just smile and just, just try to be yourself and don't let any of the barriers or the stethoscope or the white coat get in your way. You're a human being, so are they. And try to, appreciate their humanity each time you're in a room with a patient, regardless of racial background. Mackenzie, go ahead.
Hi, I just wanted to say thank you, Dr. Moore, for your presentation and for sharing your personal experiences. It's been very interesting and informative to hear. My question was kind of more in the realm of medical education. I know that so just having finished first year, we've talked about certain things like sickle cell and sarcoidosis and how they have like a higher prevalence in Black people in some incidences. And my friends and I kind of noticed for especially like the NBME, the standardized questions, we've seen like if you see like a young Black woman or a Black child, they're kind of almost like buzzwords for certain diagnoses that we've seen. And we've kind of had conversations about kind of like any pros or cons to that, and I was curious what your take on that was and how you view that.
Yeah. So again, my personal, I can personalize these things. My sister-in-law had sickle cell disease and died a premature death, even though she lived long. I think she lived longer than the average person with sickle cell because she had a very supporting family. Um, Even today, my brother-in-law and my wife are involved with the sickle cell program. But I will tell you, sickle cell is not a Black disease. It's not a racialized disease. It's a geographic disease. So I, as a doctor, again, need to understand the full scope of this. I need to teach the families, teach everybody that I know that sickle cell is not a Black disease. It's not a racial disease. It's a geographic disease. It's based on people who live in relationship uh, with malaria and the mosquitoes. It's a disease based on the equator. So there is science. Don't let the pseudoscience become the best doctor to know the facts. But as Marvin says, I had a sickle cell patient, who was an older woman. I made house calls with that patient. uh, I was able to learn, I met her in the hospital. It's important to understand this because, based on what I think Marvin is trying to tell you, I am making rounds in a room with multiple patients, and I am dealing with my patient. And as I'm about to exit the room, this woman in another bed stopped me and asked me right then and there, could I be her doctor? And I was flattered, but that was not something you ask a doctor seeing another patient because everybody in the bed has a doctor and doctors don't do that. But the fact that she asked me was that she saw something that in me as a doctor that she wanted for herself. She was being managed by the sickle cell program, the doctors that whatever. That patient took a significant amount of my medical resources, effort, whatever. I learned as much. This was, I'm talking about this patient because she had impact on me. That relationship was one of the strongest patient relationships that I had. I learned so much, and that's the beauty of medicine, especially if you're in primary care medicine, if you're in a patient facing medicine. I'm sure a researcher may feel just as strong about their test tubes, but what makes me so happy, despite everything that I've seen, that I was in the best profession ever, is because I've had those relationships. So to more specifically answer your question, um, the, the humanity of medicine, the fact that um, each relationship is an important relationship, and you don't know how these patients are going to come into your sphere of control, influence. But sickle cell, I learned more about sickle cell disease. Of course, this patient had a tragic death. It was a premature death. I spent a tremendous amount of my capital and resources fighting the system for this patient. At one point, this patient under my care was discharged onto the sidewalk, and given cab fare. This is somebody who should have been sent home in a cab or sent home in an ambulance. You know, I was able to diagnose disease that we missed. I mean, I felt bad because she had a disease in her spine, an infection in her spine that on my service I missed for 3 months, but it was persistence, her persistence, me believing her about her back pain that eventually helped us to make the diagnosis. She would have died from that disease if it wasn't discovered. It was a fungal infection in her spine, rare stuff that, we're going to miss. The statistics Marvin showed you, these premature things are happening, but they don't happen to people with resources or people who are afforded the resources. She didn't have the resources. She lived in in poor housing. Her son had sickle cell. No, her son did not have sickle cell, but her grandson had sickle cell. So she was managing at home when she was at home, her grandson who had sickle cell and her son unemployed. So there was a whole social thing there. There was me using the resources of my practice, my assets to help this one particular person. But I also knew the science. The science was she didn't have sickle cell because she was Black. She had sickle cell because her genetics, her ancestry determined that she should have sickle cell. So I didn't perceive her as, okay, I'm going to solve this problem of a Black person. I'm going to take care of this patient with this particular disease who just happens to be Black. Marvin, you're on mute.
Yeah, thank you so much. I really appreciate your taking all this time to join us. And because we're over time, let's adjourn until just around 11:20 or so. And at that point, we'll watch part of the tape from Dr. Schulman, which I'll explain why when we get back. But thank you all so much. And thank you so much, Dr. Moore. I really appreciate your coming, joining us.
And Marvin, I'll email you the presentation so you could share. Yes.
Yeah, I'll do the same for you.